أبنائي وبناتي طلبة المرحلة الرابعة، السلام عليكم. The talk of this hour will be on screening for disease. By the end of this lecture, you will be able to define screening, to describe validity and reliability, and you will be able to evaluate screening tests. We apply screening for a screened population, large number of people. Some of those people are diseased. The majority may be healthy. Screening consists of screening test that is able to pick up from the screened population those who are probably having the disease. We do screening for a disease because what the doctor sees of the health problem represents only a small proportion, or what we call the tip of the iceberg. There is a large amount of hidden disease, which is due to subclinical infection, undiagnosed cases, asymptomatic cases, carriers, and so on. In a clinical exam, the patient by himself as a single person comes to the doctor. After taking history and a clinical examination, the doctor will do a diagnostic test, and according to the results of this test, the patient is offered the treatment. In screening, we go to a large number of people to apply a screening test, which is basically not a diagnostic test, and thus we don't offer a treatment on basis of screening test results only. Screening means application of rapid tests for large number of people. Why? To know those probably have the disease and those probably are disease-free. We do screening for the community first as a primary prevention for the community, and second is as a secondary prevention for the asymptomatic patients. The time of screening depends on the natural history of the disease and knowing the timing of the different disease stages. To start with, when the patient is exposed to a causative agent, the stage of a preclinical disease starts, in which we get pathologic changes. After this stage ends, the symptoms will start, and when symptoms increase, become more, it is the usual time for the diagnosis. The patient goes to the doctor and the doctor makes the diagnosis. So the correct time of screening is before the usual time of diagnosis, during the preclinical disease, and in the early stage of a clinical disease. Screening tests is not a diagnostic test. Thus, people who are positive by the test should be further tested using a definitive diagnostic test to know those who are really diseased and then to treat them accordingly. Now, the negatives by screening who are most likely healthy, but there is a minority who are diseased, and those are not picked up by the test. So you can see here that the screening test results are either positive or negative. The criteria of a good screening test includes, first, the acceptability. Because if people reject or do not accept the test, the screening program will fail. We are screening community, large number of people. Second, screening tests should be reliable. The results should be precise, stable, not change when we repeat screening. In addition, they should be telling the truth. They should be valid. They should be accurate. Furthermore, screening tests should be quick and simple because we are testing large number of people, so time is important. And simple because usually the health staff trained to do screening, so the screening test should not be complicated. In addition, it should be safe and non-invasive because we are testing apparently healthy people. So we should not do harm for them when they are apparently or rather healthy. Finally, we should estimate the total costs. Although the screening test may not be very costly, but since we are doing screening for thousands of people, the cost of the test will be high. In addition, don't forget the cost of definitive diagnosis for the positive cases and the cost of treatment. Here you can see examples of screening tests. Snellen chart for testing visual acuity, ideally among school children. Tuning fork for testing hearing impairment, hearing defects among school children, for example. And the stethoscope is a good tool to screen for congenital heart disease among a newborn. Mammography is a soft tissue X-ray for the breast. You can see here the breast is squeezed a little by the machine to take a soft tissue X-ray pictures. This is a normal mammogram, which we call negative mammogram. And here are the photos of a positive mammogram. This is a screening for early detection of breast cancer. For early detection of cancer of cervix uteri, cervical cancer, there is a smear test which is called pap smear. We take a smear from the cervix of the uterus and spread on a slide, fix it, and do cytopathology examination for early detection of cancer cells. This is a mobile lab for screening COVID-19 in Italy. Here are examples of screening among different age groups. Among neonates, we have in Iraq what is called neonatal screening for congenital hypothyroidism, phenylketonuria, and galactosemia. In infancy, we test for screen for hearing, visual defects, hip dislocation, congenital heart disease, and so on. In pregnancy, for example, anemia, toxemia, Down syndrome, Rh blood group. Among middle age and elderly, hypertension, diabetes, glaucoma, cataract, cancer. Now, you should be able to differentiate between validity and reliability of screening tests. A valid test is a test telling the truth, measures what is really supposed to measure. To give you an example, when you put the thermometer inside the mouth of your patient and then you read the temperature, for example, 39, what you see actually is the increase in the height of the mercury column and not the temperature. But as the increase in temperature leads to increase in height of mercury column, So this height represents really the increase in temperature. So this test is valid. Validity is studied under two components, sensitivity and specificity, that I shall explain to you in the next slides. The test also should be reliable, stable. Results does not change when you repeat the test under similar conditions. If results change, this is unstable test, it is unreliable, gives us confusing results. To make it clear on this demonstration, suppose we have done screening for a large number of young, healthy athletes using a sphygmomanometer and plot the results on the chart. As you can see here, all the samples are more or less 120. They are normotensive, and this is true because they are healthy, young athletes. So the test is telling the truth, it is valid. The variability, the change in results, follows the normal distribution curve, more than 115, less than 125, slight change, which is all normotensive. So the test is also considered reliable, relatively or rather stable. If we repeat screening for the same sample using a different sphygmomanometer and plot the results, as you can see here, this sphygmomanometer makes all the sample hypotensive. It is not telling the truth. So it is invalid. But the changes in readings, more than 95, less than 105, more or less, little variability in results, so the test is reliable. If we do screening for the same sample using a third type of sphygmomanometer and plot the results, you can see this green line. There is a wide variability among results from 1110 to 130, wide variability. Results are unstable, so the test is unreliable. But is it valid? Actually, this normal distribution curve having a mean, median, and mode of 120, which is the normal blood pressure, so the test is reflecting the truth. So the test is valid. Now, if we repeat screening using a fourth type of sphygmomanometer and plot the results here, study the results and try to guess the validity and the reliability of this sphygmomanometer. Now, in order to solve problems on screening, to evaluate screening tests, to find out the sensitivity and specificity of screening tests, you should understand this 2x2 table. First, we do screening for a screen population. This is the screen population here on the grand total. This population are either healthy, which is the majority, or some who are asymptomatic but they are diseased, either diseased or healthy. And when we apply the test for this population, the results of the test are either positive or negative. Accordingly, we get a 2x2 table in which we put the disease status above the result of the test on the left. In this place, where the persons are diseased and they have got a positive sign by the test, this positivity is correct because they are diseased, so this is the true positive value. Now, when they are diseased, but the test gives them a negative sign, this negativity is incorrect. It is a false negative. From here, you can see that the diseased people includes not only the true positives, but in addition the false negatives. Now, we go to the other part of the table. The red part is concerned with diseased. The blue part is concerned with healthy. So when you come here, forget about the disease. Think only about the healthy. A healthy person who gets a negative sign by the test is a true negative result. This negativity is true because he is healthy. If he is healthy but given by the test a positive sign, this positivity is untrue. It is a false positive. So you can see here that the healthy people includes the true negatives in addition to the false positives. Now, we were looking on the table in a vertical view. Now we go and look at the table in a horizontal view. The positive signs, all the positive results of the test include two types of positive results. The true positives who are diseased and the false positives who are healthy. Similarly, the negative results of the test, negative tests, include also two components. The true negatives, the healthy, and the false negatives who are diseased. What is sensitivity? Sensitivity, ability of test to pick up correctly, to identify correctly the diseased people. So those are the diseased people. If they are picked up correctly by the test, they will be given a positive sign by the test. It is a true positive. So sensitivity equals to true positive divided by disease times 100. It is a percentage. We can call it also the true positive percent. We have a complement of sensitivity which is called the percentage of false negatives. This is percentage of diseased who were negative by the test. Percentage of diseased. Negative, so the negativity here is false because they are diseased. So false negative percent equals to false negative divided by diseased. Those people who are diseased but not picked up by the test represent the percentage of missed cases. If we add sensitivity to false negative percent, the result is 100. So if we have any one, we can subtract 100 from it to get the other. Now we come to the second component of validity, which is specificity. Here we deal with the healthy people, so forget about the diseased. Specificity is the ability of screening tests to identify correctly the healthy people. The healthy people, when they are identified correctly, they are given a negative sign, which is a true. So specificity equals to true negative divided by healthy times 100. It is a percentage. Sometimes we call specificity as true negative percent. The complement of specificity is the percentage of false positives. Those are percentage of healthy people, but who were positive in the test. Healthy people who were positive, so this positivity is incorrect, false positive, because they are healthy. So false positive percent equals to false positive divided by healthy times 100. Similarly, if we add a specificity plus false positive percent, the result equals to 100. If we have any one of them, subtract 100 from it, you will get the other percent. Now, looking to the table in a horizontal view, we have the predictive value of positive test. Predictive value of positive test, percentage of people with positive test who have the disease. Those are the positive tests. How much of the positives were diseased? How much of the positives were diseased? So how much of them have got a true positive sign? So the predictive value of a positive test, or we may call it the positive predictive value of screening test, equals to the true positive over all positives percent. This is the diagnostic power of the test. How much of the positives are diseased? Similarly, predictive value of negative test, percentage of people with negative tests who are healthy. So all the negatives. How much of the all negatives were healthy? To be healthy, the test will give a negative sign, which is true. So the predictive value of negative test, or the negative predictive value, equals to the true negative divided by all negatives times 100. Don't bother yourself with those 6 equations. They will be explained in details together with solved problems in the practical session. The final slide is to give you a demonstration how to solve a screening problem. Take a minute to read this problem. 10,000 children screened for visual defects using Snell chart. 288 referred to hospital, 890 given glasses. Now, if you know visual defects prevalence is 1%, find out test validity. In any screening problem, there are standard steps which you should follow one by one. The first step in any screening problem, draw a 2 by 2 table. Put the disease state above, disease healthy. Put the screening test result on the left, positive test, negative test. Second step, try to fill the 9 cells of the table with numbers from the problem or from calculations using the 6 formula I have stated to you. Now, the 10,000 children screened represents the screened population. So it is put here in the grand total. Now, the 288 refer to hospital. Why? Because those were positive. So they are all positives. 90 of them giving glasses. Why? Because they were proved definitely in the hospital to have visual defect. Now you can fill some cells by subtraction and addition. Still remains 4 other cells to fill. Go to the problem. Visual defects prevalence is 1% among children. In the community, we are doing the screening. Every 100 children, 1 child is having visual defects. But we have screened 10,000. So we multiply the population by the prevalence to get the total number of cases. Here, I want you to go to the lecture of prevalence to refresh your memory about what is prevalence and how it is calculated. Prevalence equals to total number of cases old and new divided by population times constant. So if you multiply the prevalence with the population, you get the total number of cases, which is 100. These are the total number of true cases with disease in the community we are screening. So this 100 represents the total number of disease and should be put here. After we put this number, now we can complete and fill the missing cells. Now all the 9 cells have numbers. We go to the problem and we can find anything which the problem asks about. Find out test validity. Validity means sensitivity and specificity. So sensitivity equals to, from the formula, true positive divided by disease percent, true positive, divided by disease percent is 90%. Specificity, true negative divided by healthy percent, true negative divided by healthy percent equals to 98%. The final step in any screening problem is try to explain your results. We say here that Snellen chart screening test is sensitive and specific. I hope you have found this lecture to be useful and you have understood the major points. Keep in mind that there is a complete practical session about screening that will clarify more the subject for you.